Good morning again. Thank you for your patience and flexibility as we're running a little bit ahead of schedule, as I mentioned earlier. We're very excited to introduce our first panel entitled Displacement and Disparities, Navigating Health Challenges Amid Conflict. This session is being hosted in partnership with the Harvard Humanitarian Initiative. Giving opening remarks for this session is Michael VanRooyen, Chairman of Emergency Medicine at both Massachusetts General Hospital and the Brigham and Women's Hospital, Enterprise Chief of Emergency Services for the Mass General Brigham System, and founder and director of the Harvard Humanitarian Initiative. Dr. VanRooyen, please take it away.
Thank you and good morning. I'm going to take off on a theme that you've already divined is a theme for the day. Prior to January 2025, the prevailing dialogue in the humanitarian sphere where we work has been in how to protect populations, how to access populations, how to find and serve populations in crisis, how to empower organizations to reach organizations to preserve human rights and to prevent human suffering. That dialogue changed in January because suddenly now we're faced with, I wouldn't say even more of a crisis, but another crisis. And that is this rapid retraction of humanitarian funding from not only USAID, but from the world, because we see other development dollars going down as well, has left the humanitarian sector in disarray and in crisis. And these organizations, their job, their goal, their mission, and their passion is to care for the world's most vulnerable populations. And as a result of this rapid retraction that I think has been incredibly disruptive, 8 organizations are trying to figure out what to do and trying to figure out how to take these rising humanitarian needs, face them, and care for the populations who deserve this. And let's be clear, without principled investment into the humanitarian sector, the world will become a more dangerous place. It is becoming a more dangerous place, right? Out of the 300 million people that suffer from, require humanitarian assistance, from the 100 million that are suffering from displacement around the world and from those who are on the brink of actually death, we're sort of pushing that over. And it's a critical time. And so this room, and largely the audience of 2,000, which is phenomenal, listening today, have 2 choices. Your choice is to throw up your hands and say it's all terrible, because it's really easy to do that. Or it's to fight this, and fighting it meaning invest in our people, in our programs, in our organizations, in our NGOs, in our UN agencies, in the organizations that do this work. And it is a time not to sit back, but a time for leadership. But it takes principled, dedicated, creative leadership that risks a lot in order to preserve this mission. And so we're here with people who think about this. And so I'm really delighted to introduce this panel of humanitarian leaders in the current era, because they are going to be talking about the large panel online and in this room of humanitarian leaders of the future. And so it's my pleasure to introduce this panel and to introduce our, oh, wow. That's good. So bust into song there, that's good. And so let me just introduce our team here, and we're delighted to have them so far as well. Thank you, Dr. Leaning. I just was talking to Jennifer earlier today that I went completely digital, and she's still analog. And so analog apparently works, so it's good. So the panelists, and I know them all anyway, so it's great. Petra Khoury, who is a friend and colleague, a doctor of pharmacy, global director of health and care for the International Federation of the Red Cross and Red Crescent. Thank you for coming. Salman Khoury, who's the director of the Harvard Medical School's Center for Global Health Delivery and a professor of health and social medicine. Great to see you. And Dick Chamla, who's also a friend and colleague, who is the head of emergency preparedness for the African region of the WHO, all really experienced leaders, all in a little bit different areas of focus, and all can really lend a lot to this. And then, it's my great pleasure to introduce my friend, colleague, and co-founder of HHI, Dr. Jennifer Leaning, who has a long career in humanitarian work around the world and is a senior fellow at the FXB Center and a professor of the practice in health and human rights. So I'll turn it over to Dr. Leaning to take over the rest of the panel, and thank you all for attending today. Cheers.
So Dr. VanRooyen, Mike, to a number of us, that was a wonderful introduction, and it spared me from repeating what I would basically like to underscore, which is that we have, the four of us together, we have talked 2 to 3 times in preparation for this event. And I have encouraged them, although I didn't need actually to offer much encouragement, although they might have been prepared to be more zipped up and more cautiously political in this talk and in this framework, and even more so with 2,000 people online. But I still believe it's important to be speaking truth to power. It's really important. And at various times in Harvard's history, it has done a good job of doing that. At other times, not so good a time. And we're basically watching how universities will manage to stand tall, find the funds, and not get their heads cut off because they're standing above the grass. But it's actually that stark. And if it feels stark to us here in this beautiful building with wonderful colleagues and staff, great coffee, I might say, if it feels arduous to us as we're looking forward, what to teach, what to train for, what to aspire to in your career, we have here 3 deeply seasoned people who are beautifully trained in their own traditions, which basically come together in humanitarian work, medical and epidemiologic humanitarian work, vast experience in different countries. I will allow them to say a bit from what power base they come from. And you all have power bases. And the order that I am introducing you to speak, Petra, Dick, and Salman, I hope is okay. Mike VanRooyen thought it was okay, and others did as well. Is that all right with you, if we go in that order? And partly, Dr. Khoury, I know that you have a very tough perspective from the standpoint of being senior in an international organization that has been doing humanitarian work for decades, and a century and a half, basically. And this is, I mean, there was World War I, which was arduous, and World War II, which is arduous, and now there's this time. And so from that perspective of how agonizing it is, could you please share your thoughts?
Sure. Good morning, colleagues. Thanks for listening. Maybe we go back in history a bit. I mean, we have to learn a bit from the history so that we talk about the future. The Red Cross, Red Crescent movement started 160 years ago, and there is a reason why it started. It started because of a battle in Italy, Solferino Battle, where 10,000 soldiers were left to die, and no one would come forward to treat them with fear of retaliation and fears of being labeled on one side of the conflict. And it was this man called Henri Dunant, who's a Swiss philanthropist. He was on his way and he saw this. And what he did, he went to the neighboring villages. He called on the women, not the men. And he asked the women if they can come forward with him and walk and give relief to those 10,000 injured soldiers. And he flipped the Swiss flag. That's why it's called Red Cross, because the Swiss flag is a white cross. So he flipped the Swiss flag and he walked forward. And since then, the mission has started that we need a neutral, impartial, humanity, independent entity that serves under different conditions and provides humanitarian service. Fast forward to 2025, where we are. The current status of what I've at least observed, I've been visiting capitals since the beginning of the year, and I have to say probably the US is the headline, but similar things are happening elsewhere. It's not only the US. And others possibly are doing it under different approaches. The US approach was the most flagrant one. They immediately pulled out the Band-Aid, but others have been doing it. And the status of my reading, at least, of the status of the world, and particularly on the global health side, attitude towards global health has completely changed. We go back 1 year ago, the attitude of governments towards global health was a bit different from what it is today. And specifically, foreign aid. When we talk about foreign aid, it has suddenly become a trade tool or a business deal. And they're lumping foreign aid with humanitarian aid. We're trying to make the distinction that foreign aid has always been an instrument of government to do political influence. Humanitarian aid, to some extent, has been shielded and guarded. That's not the current attitude. The other issue about attitude, the public attitude towards foreign aid and global health. Suddenly, this misinformation, disinformation that has been brewing since COVID time has peaked. There is a general attitude that why do we need to support people that are outside our borders? We need to keep the money internally, and all of these investments that have been happening for years are not to our best interest. It's probably the line of political influence. The second, so attitude is the first. The second one is complete disregard to the commitments that governments have done, whether to SDGs, to laws, to resolutions. Every year, ministries of health gather at the World Health Assembly in Geneva. We celebrate resolutions at the UN General Assembly, resolutions, events, and now we're resetting. We're doing all of those changes, and we're not looking at the goals that we have committed to in 2030. It's as if all of this conversation is completely gone. So the complete disregard, not only on the health side, but also on the humanitarian side. I think in the last 3-4 years, the complete disregard to IHL, the way the rules of the wars, the impunity that has risen, there is an attitude of disregarding the world order and commitments on it. The third one is the stark reality that we're currently seeing. When the Western funding disappeared, capacity also disappeared with it. And this is a reflection to us as agencies that have been working in this space. I mean, we have reports that says possibly 50% of the health capacity in Africa will be gone with the Western defunding approach. So this is for us to look at the mirror and wonder, did we do things at the best as we should have done them? Or could we have done things differently? And that's part of the solution and talking together on the way forward. Do we want to go back to January 19, or should we look at something different? And obviously the last one is commitments to ODA. Governments had made commitments that 0.7% of their GMI would go to ODA. They're not gonna. There are only 2 governments currently they're committing to this 0.7. They're Denmark and Norway. Every other government is dropping its commitment. The latest was Obviously, the US completely not there, but the latest, the UK, they dropped it from 0.7 to 0.5 and now 0.3. So we're going further down. And the last point, and I'll pass it over, the estimates that we had done before the US funding cuts were around 21.7 billion of ODA funding will disappear in the next 5 years. This all comes at a price. This all comes at what we're going to do and where are the priorities going to be. Thank you.
Thank you very much. We're going to engage further with you in the Q&A and the back and forth, but the historical overview is very appropriate. And we're going back to a time when, notions of triage were just being developed in the 19th century. And we're going back to a time when a humanitarian who was not a physician noticed that there were, on that battlefield, soldiers, men, who were dying of thirst and bleeding, and sometimes covered partially by the dead horse. There were many dead horses. And he saw this and managed to discern that there was agency that he could deploy with help. So I think it's an image we need to come back to when we think about how humanitarians are going to pick themselves up, and with that, pick others up. So thank you. So next in order, Dr. Chamla, could you speak to us about your perspective, which is actually, you have multiple perspectives. So you choose how you want to position yourself.
Anyway, I'm from Africa, and also I'm from a WHO. I'm from Africa. As I'm talking now, we have over 80 emergencies happening in Africa. And I'm only talking in April, okay? 2024, we had over 128 emergencies in Africa. And around the 20% are humanitarian crises. I'm talking of the wars we have in Sahel region. So we have now another war in which is happening in the DRC Congo. And we have others in which actually have emerged. I don't know if any of you understand, 2 days ago, we are having a crisis now of the Mali and Algeria, in which is already starting. And we have a closure even of our airspace at the moment. It is Africa. And I'm saying I'm also from a WHO, because if you have all heard, United States has targeted specifically WHO to withdraw. And as a result, I'm here now, I'm having two hats. I'm from the region in which we have inequities over years, highest maternal mortality happening in Africa, the higher rate of public health emergencies and conflicts happening in Africa. And also now we are having an impact in which we have an abruptly cease of United States assistance. And from our preliminary assessment, we are clear now. We understand over 24 million people in Africa who are living in crisis will have the lack of access of health care. And will have displacement. And I always tell the people, at the time we have a population in displacement, we also have health workers who are also displaced, okay? As we've had here, capacity issues. Here is also a capacity issue. Another issue in which I'll be also interested to be talking up here is if you analyze the initial impact, is actually international agencies in which are actually heavily impacted. As a result, is slowly we're starting to see a threat of the multilateralism. And a threat of the multilateralism, you have heard here is an international global health architecture in which it was created over 80 years ago. Okay, breaking it abruptly, actually it has its own implications, okay? As a result, and the problem is we are breaking it and we don't have an alternative to substitute, okay? As a result, we will be ending up with global health chaos at the end of the day. And I heard here the people were talking abruptly, it sees of United is a crisis. It isn't only a crisis, it is a catastrophe. In Africa, we have programs in which are heavily dependent on US, HIV. Yes, with TB, we've had it here in the morning. So we have malaria. And in Africa, we had an excellent progress toward SDGs, as you have heard here before. And our worry is we will have actually a reverse of a progress toward SDG and actually progress in the elimination of actually a number of the diseases. And if we talk here on the issues as access to ARVs, we had PEPFAR, it was USAID. It's actually ending now, supporting to Africa. And the ARV impact on opportunistic infections, including TB, it was actually enormous. And as clinicians, we actually recall at the time of the heydays, at the time we have actually a pandemic of HIV here, we had clinical staging of HIV in which we had Kaposi sarcomas, whatever. And actually we ask it, in Africa we don't have it here now, okay? Yeah. And with abruptly stop of ARV, we are returning there again. And we will have issues here actually in the future. Okay, now you have another area in which we are actually not talking about. We've touched it a little bit here, Petra. And it is on the attacks of healthcare workers. I'm sure all of you have heard what is happening now in Ukraine, in Gaza. Actually, health workers are every day attacked nowadays. And the statistics are really dire. Actually, every minute a health worker is attacked in the world, okay? And if we are talking of health workers attack, we're always talking in relation to conflict, not actually. So we also have healthcare workers attack in public health outbreaks. In Malawi, we have realized, because on how we are handling actually on the dead bodies after the outbreak of the cholera, actually we have the body bag in which are black, we spray it with the chlorine. It is actually against a religion and culture. And we had actually health workers who were actually even attacked. At the time I was in Afghanistan, I spent 2.5 years in Afghanistan. I was actually present at the time Taliban is taking over, okay? And it was also interesting. It was interesting because at that time we were organizing a campaign of the polio. Health workers were attacked too because of issues associated with Osama bin Laden and others, okay? And on the last point here, I'm talking, there's actually 2 points. On the last one, on the issues of the impact, in Africa now I wouldn't say we actually used to. At the time we had a pandemic, actually they already left us alone in terms of access of PPE and the vaccines, okay? As a result, in Africa, it isn't really new. And also at the time I was in Afghanistan, we saw it also. It's where the Taliban has taken over and entire international community stopped. And remember, at that time, we were implementing a contracting out mechanism in health. It means NGOs were having the money, almost $200 million every year, from the World Bank, supporting healthcare. And it all stopped immediately. And we really struggled at that time. And also we had the moral issue at that time. So we had actually the choice either to try to help the population in need of humanitarian crisis or actually collaborate with the Taliban, a non-state actor who has a track record of abuses of human rights, in particular on women. The result, it was interesting time at that time. Actually, the issue we have now, how do we do about it? And in Africa is an issue we've been talking now. We are slowly sinking. Other people are taking a global crisis we have as an opportunity as well, an opportunity of reforms. As you have heard now, actually humanitarian architecture is reset. We have an opportunity now of telling our government increasing domestic allocations from its own budget. And also we have another opportunity to actually strengthening the regional institutions in which we have. Actually in Africa, we have African Union agencies now in which are starting to come up strong. We have Africa's CDC, we have African Union Humanitarian Agency now, it is already created, okay. At the same time, WHO and other agencies will be reforming slowly or actually in high speed. We don't know at the moment. In the WHO, we will have to, as you know, the last year, the contribution of United States, actually in the WHO, the budget is around 20%. Actually, we don't have 20% anymore now. Okay, therefore we will have to actually to adjust. In Africa, in the last biennial budget, United States it contributed around $180 million, and up to around 30% it was supporting emergencies, including mpox particularly. Okay, actually it has already now gone. Okay. And we will really have to think as an option. Where the multilateral banks, we've been talking about it. African Development Bank is starting to come up now with improving of health infrastructure. Therefore, we don't really see the impact up to now. So we have other ideas at the moment to see how about the private sector. From literature, we understand there is almost 200 trillion US dollars actually in the hands of the private entities.
Are you speaking in Africa?
Globally.
Okay.
Africa, 210 in private, I doubt. Therefore, how do we actually have access of that? We don't have an answers now. And the last point here is we've talked of EU, as an alternative. We have realized it won't work now. We have Ukraine war, the budget also is reducing. Okay, as a result, our options are limited. And it's an issue in which I feel how we'll be talking. Thank you so much.
You've done a rapid sweep of the globe, really. You didn't mention South America, but it is, but you could have, I'm quite sure. The sweeping disarray and the rapid rise of old and new crises is really upon us. And the options are, some of the options haven't actually been explored, but the ones that people on this panel know about and have explored, the options are pretty limited. So our third speaker, and we do have time, but I'm going to want to have questions from the audience and come back for you. So Salman, can you talk to us from your perspective of the decline and fall, however you want to personalize it?
Yeah, so I'm grateful to go third because our colleagues have said such wonderful things, and I will be short.
Not necessarily, just concise.
Be concise. Obviously we've had a number of conversations about this panel, and obviously this is something that's been on all of our minds for a while. And I start to look back at this kind of change in moral orientation towards the sanctity of life, towards caregiving to other people. And I wish we could point to January 20th because it would be a nice, clear marker, but I think it starts well before that. And I think in particular about the wars in Iraq and Syria. And without going into the details of the war, you know that many people died, and hospitals were bombed, health workers lost their lives, I think 1 million children in the first Iraq war, et cetera. So I'm not going to belabor that point, but it was, we've gone through some very incredible events where decisions were made that, it's worth life to do X. And I think at around the same time, it's given rise to an erosion of the international rule of law, and Petra, as you've alluded to, and I think in particular of something that we probably don't think about enough, but I have a student that's working on refugees that live on these Greek islands, that they're brought there as their first entry point into Europe. Many of them were telling tales about how their boats were boarded by EU frontier agents, their engines were disabled, and they were towed to the current that supposedly would take them to Turkey, and they were left to drift at sea, boatloads of refugees. I think about when I was invited by our colleague Michael Knipper to Germany to look at the situation of Syrian refugees who had walked across Europe. They had TB rates of 1,000 per 100,000 by the time they arrived, and had, again, these harrowing tales to tell in what are the most developed countries in the world. So, and of course I'm grateful that Germany was providing care. I don't want to knock them for that. They were thinking about how to deal with it. But it's, this did not start in 2016 or 2024. And, I've spent most of my career working with Partners in Health, 30 years, and a significant part of that being with Harvard Medical School. And we've been trying to deal with disparities and people's displacement from healthcare in different ways, not through wars, but just living in communities and dying. And just to put it into perspective, TB, the disease that I work on, and John just wrote a wonderful book about it, we'll hear more about it, that's, about 4,000 people or more die every day from that. So it's kind of stunning, right? And so when we think about displacement and disparity and the sanctity of life and the importance of not killing people because you have some other goal, that goal could be profit, that goal could be something else, that goal could be some outcome of a war. I think that has eroded over many, many years, and we've watched it happen in slow motion. And I think, when we were seeing kids put in cages at the border, obviously people were affronted by it, but it just went on. People elected a new president here in the United States, and the same, camps at the border, thousands of people waiting with an app to, get their asylum claims. 80 people a day or 100 people a day were taken on the app, and 50,000 people waiting. That just marched on, regardless of who was in government. So I think we really have to think about how historically deep this is, and this trend since the 1970s and 80s that have allowed for this degradation of I would say the moral order. There's a moral order that's degraded, and I think that's part of it. The second thing is that, if you look at countries in Africa and you look at countries in Asia, I actually, in this post-USAID period, I have, I think what we've seen is that we've lost a lot of the commodities that USAID was giving. I think PEPFAR talks about that, and the infrastructure that you've mentioned, Dick, that there was a mechanism to get commodities to places and for it to get to patients who need it the most. And I just this morning before this panel, I was on a call with the Ministry of Health of the Philippines in a project that Partners in Health is working on there to help them scale up TB care. And it's interesting to see that this has kind of also changed the orientation of the ministries. The discussion was, in the absence of USAID, what money can the government bring to bear on making sure that people get their TB meds? And I feel like we weren't having this conversation 3 or 4 months ago. And I know that I'm talking about a middle-income country. I'm not talking about an ultra-poor country. There's a difference, so I'm not making a blanket statement. But there's that kind of glimmer in the background that you're like, okay, it's not going to be perfect, but people are seeing that they need to rise to the occasion. And I don't know the mechanisms. Dick, you probably know it better, and Petra, you do probably as well. But I should imagine that when countries are having these types of emergencies, maybe they don't pay extractive loan interests at the same rate, and maybe they don't do other things because they can declare emergencies. And so I just wonder if this opens the door to a whole different game where people can say, we value the sanctity of life and we just don't want this many people to die, and so we cannot, we have to prioritize HIV medicines or TB medicines or diabetes medicines for that matter, or whatever it may be, right? So I think that there's that glimmer of hope in recasting this order. And then just the last thing I want to say is that, as we have to have some honest conversations about this, because we know that even with aid, we see outflows of large outflows of monies from places like Africa. And there's all these graphics that you always see with these big arrows coming out and little arrows going in. And so, we've kind of grown up with those graphics and take them for granted, but they're kind of part of the problem. We've also had Western countries, these wars, there's 35 wars happening in the world right now. They're not happening in a vacuum. They reflect some of the post-colonial tensions, but they're also fueled by arms sales from the very country we sit in and other places. So, this is, I think, a multifaceted thing, because the wars aren't happening in a vacuum, and the decisions to bomb hospitals or to kill health workers or to say, this is worth it and this is worth that, those are actually very political decisions. They're moral decisions, but they're political decisions. And so, it's not only in the United States, but in Canada and all of Europe and Australia and New Zealand and all these countries that are part of this have to really take us, and it could actually be in China and Thailand and Indonesia and Malaysia and around the world. People actually have to really be saying, this is not the moral path we want to take. And unfortunately, I think there's been a lot of kind of wait and see. And while the wait and see is happening, thousands of people are dying. I was on a call with people from the Eastern Mediterranean Regional Office of the WHO talking about emergency assistance just a few weeks ago. And when they were describing what was happening in Sudan, what was happening in Yemen with cholera, thousands of people are dying. So we think of Ukraine and Gaza and other places as flashpoints, and they're terrible flashpoints, but there's some other really terrible situations and facing the same situation. So let me stop there. Thank you.
Thank you. That was a good sweep of the world in terms of the complexities and the evolution of cracks and fissures, complexities and contradictions in the humanitarian world that has been created during these decades. And it's not refreshing, your account. It's not restorative, but it is a practical way to say it hasn't ever been excellent. And there are many ways in which it has become degraded over time. And gamed by middle-income countries that are suffering, but they're not contributing a lot. So I think you're pointing a way towards a reconsideration of what it is in terms of humanitarian assistance and humanitarian relief, and what sorts of partnerships and responsibilities now need to be identified and distributed and reified. And that's hopeful on some level. I do think that the political environment in the United States right now, and I'm speaking a bit personally, but also just widely reading what's going on in this country, is astonishment and fury among people who have been working in areas of poverty and deprivation and misery in this country, but also overseas. And it's very, very good that I hear a robust kickback from the sense that what you're talking about, Salman, but I think we should hold on to that. It's going to be pretty miserable, though. It's going to be pretty miserable. And we have about, by this timer, we have about 30 minutes. Is that correct, in terms of those of you who are keeping time? And I'm not quite sure we do have 30 minutes. One never knows. So why don't we take a few questions from the audience, and then whoever on the panel wants to respond to it, or you can direct your question to one of our 3 outspoken experts. And we'll do this very quickly, okay? It won't be for everybody, but just, a few questions from the audience. Yes, sir.
So this is from the online query of 2000.
Would you tell everybody how many people are online?
Yes, I believe there are close to 2,000 people watching online. We have some questions coming in. The first is, given the recent funding cuts to health and humanitarian aid, it feels like we're facing a historic opportunity to rethink and reform global and humanitarian health. What do you think and what do you see as the next tangible step to move this transformation forward?
Well, that's an excellent question. Salman, you were talking about it to some extent. Yeah. I'd like first to hear Petra's perspective, and we could brief one, because it's a very rich and comprehensive question, so thank you. You know this international order, and you historically spoke about how it has arisen, and the ICRC has also risen and fallen and been in sad shape in World War II, and come back. It's very early, but what do you think might be the evolution of those 2 major international humanitarian agencies, ICRC and IFRC, but also in their role as leaders of how truth gets told, how people are protected, how realism dominates idealism, but the idealism is always there?
I wish I had a magic bullet answer. It's not. So this conversation has been happening at Geneva level. All the peer organizations were all thinking the same. I think the first few months when all of this happened, or the first few weeks, everybody was in complete denial, and we all thought that we're gonna resist and change. Everybody now came to the reality that we have to do things differently. 2 years ago, talking about ICRC, also ICRC went into a financial crisis. They had a deficit of 800 million on their budget, and they had to go through a complete reform, and they did. So one of the key drivers of the reform is go back to your mandate. I think all of the international agencies and organizations, we have to look inward, the first thing we have to do, and go back to our mandates. We've all overflown to fill voids and vacancies and come in and do things that were not at the core of our mandate because no one was doing them, so we picked up the work. And so it was a caravan of 2, it became a caravan of 100 because along the way, ministries of health or governments were not doing what needs to be done. And so we ended up picking up as humanitarians the work of others. I think what Salman mentioned about ministers of health trying to figure out new ways of supporting their health agenda or their national health plans. What I have seen, and this is prior to the recent days, the reason why we operate the way we operate is because the funding and the way the funding comes is very vertical. If we want to reform anything, we have to move from the vertical funding. And what I mean by vertical funding, PEPFAR, HIV. We do nothing but HIV because that's what PEPFAR does. PMI does only malaria, so we only do malaria because that's what funding does. That's what we have to do there. Polio eradication, so we're only going to go immunize 0-dose kids on polio because the funding says polio. We're not going to do anything else. So we're going to show up in this remote village that kids have not seen a healthcare worker possibly for 10 years. Because that's when we go, we find kids with 0 dose, 10 years old. So they have not seen a healthcare worker for 10 years. And we're only going to give them 2 drops of polio. Because that's what the donor said. That's the funding says this. As a grassroots organization, we face major challenges with this narrative. It's an ongoing pushback from my side to donors to say, we cannot do this. These are operations that are highly costly to set up in regions that are extremely dangerous, remote. There are no setup there. We cannot show up. I mean, most of you here are healthcare workers. I mean, if you show up in a village that they have not seen a healthcare worker, you would imagine the questions you're going to get. And from everyone, from the mother, the father, the grandpa, the grandma. I mean, everybody's going to rush to that one healthcare worker that most of the time goes on a bike with the vaccines in their backpack and shows up, has nothing else to provide as health services. So one of the reform looking ahead is going a bit horizontal. Let's do integrated health services. The funding is scarce. We can do more for the same value. We can go to those remote areas, give the polio drop, and do something a bit different, like something else, provide mental health, psychosocial support, primary health care, give other services which are not as costly if we want to do it on another round. There's in one of the countries where we do health programming. I was talking to the health director, and she said, on Monday, we distribute bed nets for malaria. So the van goes, gives bed nets, comes back. On Tuesday, we take our polio vaccines and we go again. We give the vaccines and we come back. On Wednesday, we go to do first aid training because the funding is on first aid for Wednesday. And so I have the same healthcare worker and you're getting paid from here, and then here, and then here. This is for us all also to push back and ask donors. And I was in DC earlier this week. And the discussion at the Hill is also pretty much similar. We have to do integrated health services. Again, don't quote me. I mean, they're not sure how, but yes, but they're looking, but they're looking on doing things a bit differently, and possibly because of the less funding, there is an opportunity now of doing things differently. One, inward looking, going back to our mandates as international organizations. Second, outward looking and discussing solutions such as pushing back on the prize. It's sexy and flashy to say we eradicated polio. We're not going to eradicate diabetes. So that one, primary healthcare is not as flashy. So we keep funding polio because there's a cup, there's a prize at the end of the road. There's no prize for diabetes. Thank you.
So you have your time to respond. And then I thought there's a question over there. The question that was asked from the remote audience was pretty rich. So first of all.
Oh, me?
Yeah.
Okay, I'm seeing here.
Well, 22 minutes.
Want to speak. Okay, yeah. Actually, reform is really an interesting word.
I don't think you're projecting.
But
is it? It's working? Okay.
Oh, it's working, eh?
now it's working, yeah.
Okay, I agree, actually. And it's really, really an interesting issue here. It is brought on the reforms. I think a right word here is aggressive reforms, because the word had been already initiated, the reforms, in a long time, even in humanitarian crisis. I'm sure you all clearly have a recollection on the humanitarian reform. I think it happened in 2005, in which we created cluster approach, okay? And actually, an outcome, we had a number of clusters, around 11 clusters, I think. And we added inter-cluster in the coordination platform, and we created OCHA.
Yeah.
Okay. In 2006 in Istanbul, we had International Humanitarian Conference, in which we added another platform of humanitarian development and peace nexus. Actually, it grows also on its own as a platform. We also had a grand bargain commitments as well, in which we emphasize actually the cash programming, etc. As a result, we had reforms already happen over years. The issue is we didn't have a right speed. Here now is an opportunity of increasing to become aggressive more actually on our reform. Actually, on the donors also, I think it was in 2006 we had the Paris actually declaration of the donors in which we created SWAP's approach, in which the principles of SWAP, it was actually creating the basket funding, and actually all the donors have the money in health in one basket. And I remember at that time we were told that at the time you are creating a SWAP, actually in your country, a principle it was actually create in every area a ceiling. And if, for instance, health has reached a specific ceiling, it is okay to have the money to be directed to other areas of work. So we had a lot of our donors refuse. They say, no. Our mandate is only health. How are you taking the money, example, in agriculture, okay? The reason what I'm trying to say here is we had the reforms, and actually we have to restart and to relook where we stopped and actually accelerate our speed. And I really like integrated approach, okay? I'm sure all of you remember Swed Almaty Declaration on primary health care here.
Maybe not all the people.
And after Almaty Declaration of primary health care, we had Astana Declaration of primary health care. It's all on the reform, trying to emphasize the principles of the primary health care. And one of the key issues, it was an integrated delivery of service. It didn't happen. Okay. Our problem is us. We have to relook where we started in terms of reforms and actually how are we able to actually increase or accelerate our speed.
Well, I mean, what you're describing with deep bureaucratic knowledge and also clinical knowledge, the two of you, is sort of a crisis of the humanitarian community and how it has become so complex, so rooted in rivalries, so driven by the egos of donors that it is essentially impossible to be efficient at the field level. And that was a major concern of the Almaty Declaration. It was primary care for all at the grassroots level, although I'm not sure they used the word grassroots, but it was essentially, let's clean this up and get efficient and realize that our major concern is who is living in misery. And there are a lot of people who are living in misery. So it was a wonderful question. I think you both have given wonderful answers. And sir, you in the back, you've been most patient. Could you ask your question? And I'm going to warn Salman that he's going to be the first to answer it. You need to get to a microphone. Yeah, thank you. And if you could just introduce yourself briefly.
Can you guys hear me?
Yeah.
Okay. Hey, everybody. Thanks for coming. My name is Eli. I'm a pediatric resident at Boston Children's. I'm also an investigative journalist. I have 1.5 questions. My half question is a follow-up to what we were just discussing. I was just having a conversation with Hamid Jafari, who a lot of the people in this room may know this morning. One of the things we were talking about is not only is there this problem of efficiency of delivery of services if you only do polio on Tuesday mornings, but also this problem of distrust. And so I'm curious, in an increasingly fragmented world of global health delivery, including a world where some organizations may not survive and others may survive, how do you combat the burgeoning issue of distrust, not only sort of this theoretical soft power, but literally people may not, if they don't believe that we're there for the right reasons?
Sir, that's a 100% question. That's not half a question. Could we grapple with that? Let's do a little triage here. Is that okay? That's a huge set of issues.
Absolutely.
Okay, thank you. All right, Salman, you're on first for that. Again, briefly, because we do need to, have some sort of sonorous closure.
Well, so I want to say a lot about that because I think there's a lot of distrust. And, over the years, we've had a lot of international organizations working with very little accountability. And I just know from our own work in tuberculosis, the United States had a policy of how to treat TB in 1962. Developed in 1957, made international policy in 1962, and that was to find people with TB using X-rays, give them the proper drugs, and give them preventive therapy. Just really simple stuff. Difficult to do because you need health systems, but simple stuff. And it wasn't actually made into WHO policy for countries until March 4th, 2018. 2018, from 1962. And so countries were told to do less than that for various reasons, linked to they'll get confused, they don't have the capacity, et cetera, et cetera. And I know that in other disease areas, there have been similar things happening. And I guess, if I were sitting in the countries and I were told to build a system that didn't actually meet the needs, and then suddenly people are like, oh, you need to do integrated care, I think that would be difficult to just absorb suddenly. Again, I'm going to just jump back to the Philippines because it's been on my mind recently. They've got some major health problems, one of which is TB, one of which is diabetes, one of which is maternal death, one of which is infant mortality, right? And it's, as you say, if you go to a village and you just do, like say you screen somebody for TB, but you don't check if they're pregnant or, do whatever else, to screen for diabetes, it would be insane because you're rolling out this entire operation. And that's precisely what people propose should happen, not integrate, because that's the way the ministries are set up. And the ministries are set up that way because the WHO is set up that way. And so it's just this whole cascade. And so I think that there has been distrust. And I know that because I know that every time I've gone to a place and talked about the simple search, treat, prevent things, I ask the people that I've spoken to, so what do you think? And one of the things people sometimes say is, we're really angry because we were never told that it involves this. And so I think there's that element that we have to be mindful of. The other thing, I just think as citizens in a I guess a democracy, we need to be thinking that, when you think about outflows of capital from Africa and aid dollars going in, the outflows go to the private sector and the aid dollars come from the public sector. And we've been actually underwriting that flow for decades, probably centuries. And so we have to be starting to look at what is happening from the public purse. There's a lot of nostalgia about US aid. Anybody in this room that's worked with USAID knows that there are deep flaws. There are deep challenges. So those of us that want to rise up and say, put it back, should be saying, put it back, but let's fix some of the things that weren't working out. The WHO, same thing. I don't think one should pull out from these organizations or destroy them. But I think we definitely need to be thinking, how do you rebuild trust in the communities? And then the last thing I just want to make is a broader thing about healthcare, the healthcare agenda. Hospitals are critical, right? People need them. If you need a heart transplant or you need surgery, if you have your appendix burst, you got to have a hospital. But more and more people in the 21st century, we're finding that more and more there's diseases that kill people that need to be diagnosed and treated in the communities where they live and work. It could be high blood pressure to prevent strokes and death from heart attacks. It could be diabetes, et cetera. TB, HIV, Hep C, mental illness. You go down the line. Those are not the systems that we're building. We're building these vertical programs, yes, and we're building large hospitals that become profit centers that are built on the United States model, which has not shown itself to be highly successful.
Get to the issue of trust here.
So I think we'd have to actually, sorry to talk around your point, we'd have to basically get back to saying, what is the focus of this work? It's to improve people's health outcomes, to improve their opportunity sets, their capability sets. right? That's the purpose of this work. And I think we've kind of lost our eye along the way that these are just these aid programs. The argument that these aid programs were not extensions of countries' foreign policies is utterly ridiculous. They've always been extensions of countries' foreign policies, and that's why they probably haven't worked very well. So I think we need to say, what is the outcome that we seek, and how can we best use this money? And maybe the outcome is we don't really want to help people, we just want to have boots on the ground so we can control ministries of health. That would be an outcome, it would be an honest outcome. But if the outcome is to actually give care, prevent death, preserve the sanctity of life, then we have to think about how we're going to orient that.
So, there's an old and hackneyed little phrase, every crisis brings an opportunity. That's too small a phrase for the debacle we're facing. But I do think, and the speakers here have very frankly spoken about their distress, what is in the process of being destroyed, how difficult it is going to be to return to something that is integrated and sane and merciful and strength-giving, capacity building. It's not as if the system that has been destroyed by some sort of auto pen in the White House is the only system that we're capable of. And I do believe that we have an opportunity, and some of you on this panel are more certain we have an opportunity than others. I mean, I can feel there's a different tension of dismay and, what's next. And that's completely human, and also it's bureaucratically plausible, depending upon where you sit, what you can envision. So from a university and NGO, our man in the middle here is, fired up and ready to go. And the two flanking him are, deeply embedded in international organizations that are wonderful but cumbersome. And so there is and cumbersome with all the edges that any of us who've done field work or have met them in the field understand. This is, the sort of the French word, this is a bouleversement. You have to tumble and roll over and then stand up and get your head clear. It's a impossible position to put the world in. It's a really incredibly irresponsible set of actions that have forced this, and not just on the United States, but as we know, on the world. Not that the reach of the United States is so vast, and you can hear there is a lot of criticism from the three seasoned panelists. There can be many criticisms they make about how governments and other organizations work elsewhere in the world. So this is a time of crisis for sure, and I can already hear from this group and from the audience glimmers of opportunity. But I don't want to end on a high note, actually. Because this is a desperate time in terms of humanitarian response. Because remember, humanitarian, these are people who are the clients of agencies and universities and healthcare workers and scholars. People in real need are going to have a much harder time for a while. And so if we could close, because the question from the floor or from the listeners is going to take quite a long time to answer, all right? So I know you have many good questions from our wonderful audience, and there's many good questions here from this audience. But I would like to, each of you in closing, because we have about 6 minutes, huh? So max 2 minutes, and then we might get to where we need to be. What do you think you're going to do in the next 6 weeks to try to make sense of this? I know that's an impossible question, but I know that you also, you're busy, skilled leaders, and so you have to have a sense of what you're going to do. And Petra, could we start with you? Because you're pretty precise, and you don't talk too much.
Okay. I think from our side, we're definitely going to have to do better choices. And what I mean by better choices, we have to come up with solutions. We're going to have to stop talking about the problem. We all know the problem, and it's been very well chewed and time up to swallow and find a solution. Our focus is really going to be co-create solutions, advocate in capitals what are the things that can work and see if we can influence. It was mentioned here, but it is no secret that foreign aid has to match politics. And so there is a change in politics, and we have to read this change in politics and how the geopolitics is changing and figure out how the humanitarian aid solution comes in the midst of this and try to shape it in the best way possible. We do have ideas, the vertical one is one of them. The integrated health services is another one. Localization is a third one. We talk about it, all of us. I don't think we have a right definition. Each one of us has a different definition of localization. For us, localization is strengthening the local people and their systems. For others, localization is hiring national staff. They look at it as localization, and then when they leave, the national staff become jobless, so they have not strengthened the system. So these are just things to think about, but those are the things we will be advocating in the next few weeks.
So I'm told we have a little more time.
Okay.
Yeah, so we've got, 5 more minutes? 10. Okay, so you are succinct, and you've set the stage beautifully for how you're going to work in the organization. And what strikes me is that there's a we here. You know who you are. I mean, it's good that after 160 years or how many years you're going to claim that your organization still knows who it is, and that's a triumph. And so you're already figuring out who is going to do what and how you're going to think about this. You're not talking too much about how you're going to lead or participate or work in a group to rewrite the sort of structure of NATO, but you're speaking essentially about the international Red Cross and Red Crest movements, right? Mm-hmm. And yes. I think that's the sort of discipline that we would hope and expect would come from you and your colleagues at ICRC.
I think as a membership organization, when we work, and particularly during these difficult times, we leverage our grassroots. So American Red Cross here in the U.S. is supporting us with the U.S. legislations to help us shape up some of the international policies, the German Red Cross with the German government. So we're activating our network to influence as we come along in this journey. We are doing an internal relook as we speak. The organization is going into a massive survey of how do we want to operate in the next 100 years and how we're going to do things. Again, going back to mandates. Yes, we're going to have to walk away from things that, unfortunately, we're not going to be able to do them, and others have to either do them. Governments, they have to assume their responsibilities. Working as a charity for all might not be the way forward during this time.
So I'm going to turn, thank you. I'm going to turn, Salman, you're going to be last because you're not quite in the nested UN or Red Cross movement structure, right? You're more of a free agent. So Dick, will you talk about, from your perspective, WHO, but also WHO as it links up with virtually everybody else. What do you think you would want your outfit to do, or what are you trying to make happen? From where you stand, what are the steps you're going to take?
Yes, actually in a WHO, we view it actually in the two areas. As you all understand, the WHO is a member state organization. Therefore, we are only acting as a secretariat, actually, of our governments. So we have area in which it is priority about the WHO itself as an agency. And we have another area is how are we able supporting our member states to navigate what we are now. Therefore, in the WHO, as we've already started it, action one is to reprioritize, to clearly try to look inwards, as we've said, to clearly understand what are our core mandates and what are the priority issues in which we are having now. And on the last part is to really try to understand who are our strategic partners at the moment. Actually, health is really interdisciplinary area of work now. Our 2/3 of high-threat pathogens are from animals. As a result, we have to see how are we able actually collaborating with other agencies actually in the world. Therefore, it's clear priority to reprioritize, and at the time we reprioritize our activities, we will also restructure our organization, actually in one or another, and two, to understand what are our strategic partnership. The last one is resource mobilization. We have to find actually other sources of resources in order to actually implement our activities.
Could I interrupt there? Because you are a unit that coordinates on certain parameters nation states,
Yep.
You will be looking for more funding from the nation states.
Exactly.
Correct?
Yeah.
'Cause that's a big deal.
It's really tricky at the moment, as we've already talked here. In the past, everyone was talking, actually, if we don't have the US, will have EU. And we've realized it doesn't happen like that now. As a result now, we have already started talking to our member states themselves. Therefore, WHO have created now investment rounds in the countries, and in Africa last year we had our investment round in the Regional Committee of Africa, in which all our ministers of health are coming, and we had our pledges closer to around $50 million. Actually, it's a pledge. It isn't hard cash anyway, and it is actually one of our approach in terms of resources. At what our member state, I think the critical issue now, particularly in Africa, is to increase awareness of the impact of the USA in this issue we're talking about here now, okay? Actually in health. As you know, we have African Union in Africa, in which almost 15 years ago it declared Abuja Declaration. And under Abuja Declaration, the member states were actually required to actually increase allocation on health to around the 15% of their budgets. I think until the end of the last year, only 2 countries have reached that, okay? The result is to increase awareness and actually to increase the commitments. How do we do that? I think WHO, we already started to actually, to bring the parliamentarians now actually in the picture, because we view the parliamentarians and parliamentarians are the people representative, are creating laws, approving budgets, and are also are holding accountable to the governments. The result is an interesting stakeholder to bring actually on board in this time of crisis. Over.
So, someone you've been very patient. I would invite you to speak from your perspective, but in the context of what are 2 leaders from very esteemed international organizations have both said, which is figure out priorities, figure out strategies, figure out ways where you, the Red Cross movements and WHO can function well and improve analysis and delivery, and there are many steps for doing that. Where you sit, if you can define that, because you have many roles, but partners in health, NGOs, academia, I'm giving you a broad tablet here, but so I do want you to be precise. So as I'm speaking to you, think about what you're going to say, because you have you have some time now. I mean, we've got maybe 2 minutes, and I may say something brief at the end, but you're sort of our closing batter here.
Well, I'm glad you didn't want to end on a positive note, because I do think that a lot of people are going to die from the changes. They've been very abrupt. They've shocked the system, and even if one has issues with the way the system was organized, it was organized in a certain way that could deliver care, and I think that is the crisis that we face. And organizations like the WHO, like IFRC, ICRC, I think are critical. Any of the situations we're looking at, we could be looking at Sudan or Gaza or Ukraine or Mozambique or wherever. Even if there's not a war necessarily, you see that the WHO are critical partners, and you see that the Red Cross is a critical partner. And I think what I'm seeing more on the ground is that this opportunity, people are going to lose lives, but there's this opportunity for countries to take a little bit of ownership. And by countries, I don't mean the governments necessarily, because I think one of the things that we've seen is local NGOs are there. And so I wonder if part of the realignment that maybe helps with the cost, but also, takes away a little bit of the coloniality that's kind of been imbued in this whole thing for the last few generations, could local partners really take the lead on some of the things with external funding? And I think we've heard that we do need to continue funding from governments, but maybe it needs to be done in a slightly different way. Development Inc. maybe needs to change a little bit, and it has to be, affected differently. We've tried to do that at Partners in Health. It's partners on the ground that are running most of the things, and I think that there's been kind of like a pullback from having outside people always going in and rather having more people on the ground. I'm seeing that now, as I keep mentioning the Philippines to you because it's on my mind, but I'm seeing that there too. There's local NGOs that are like, oh yeah, we can get money for this or that. It's not big money. It's not $50 million or it's $100 million, but it's something to keep the work going. So, I think we should have despair that lives will be lost, but also we should try to work and get some of these other avenues functioning well. And maybe if funding from Western countries increases again over in the upcoming years, it will complement that. The other thing I think I've heard both of my colleagues say, and I think it's so important, is we have to be talking to legislators and educating them, because I think there's a lot of. I was talking to one of the U.S. Congress people a couple of weeks ago, 3 weeks ago, and their team was not aware of that TB was airborne and such a dire problem for the U.S. and cost the U.S. economy it's between $7 and $11 billion a year, and that we have 750 military bases, and et cetera, et cetera. So even if one looks at one's own self-interest, there are reasons to be acting externally. And we could be talking about Zika coming into Texas. We could be talking about Lyme disease moving to the northern parts of the country. You still need to be thinking about these things, right? So I think that's the other angle where we are really going and educating people. So it's a dismal moment. There are these glimmers of hope, and we really have to try to think of how we're going to rebuild the system as we're moving.
Thank you.
Easier said than done.
Well,
easy to say from an NGO and academic perspective, but I think it is doable.
Thank you. So I'm going to close now, okay? Even if we might have another 2 or 3 raggedy minutes. I mean, from my perspective, the 3 of you have been really remarkable interpreters of the dimensions of this crisis and great interlocutors for your constituencies, your outfits, and have left us with a bit of a sense that there's running room, that universities, students, young professionals, I'm sort of scanning the audience, that this is a time for initiative and also solidarity. And it's a time for people to start talking to people in the dining halls or in the restaurants or in your wider friendship circle about a certain aspect of mobilization. We're going to need you all. Truly, we're going to need you all. Because there's going to be more misery. And that's unmistakably a problem in the United States, where there's already vast latent misery that we have not addressed. But it's true throughout the world. So it is a challenging time. It's a time where it's going to be harder to get money from various sources that we have thought we could get money from. But it is a time for speaking to each other about how tough it is and what you still want to do. And don't give up on what you still want to do. You're just going to need allies and confidence and a perhaps slower and more articulate sense of advancement. It may take you longer to do things. You may have to do lateral, sideways work. You may have to do something else for a while. I'm thinking of how you're trying to pay for graduate school or you're trying to get through certain training periods. There's going to be less, from the United States perspective, less government and state largesse. And for those of you who are from elsewhere in the world, you can tell from our speakers, there's definitely going to be less money for them. So that means it's on your initiative. It's on your sense of bounce back. It's on your sense of not giving up. I mean, there needs to be a bit of a campaign mode here, so that this very strange government, I'm putting government in quotes, it's hardly a government, this very strange regime doesn't crush aspiration and doesn't consign larger numbers of people to misery. I'm scanning the room. It's such an impressive group of people. And I have a sense of solidarity with the 2,000 that you're monitoring. This is the sort of thing that you see in wars sometimes. People do everything differently because they have to. This is a different kind of crisis, but we need to have all of you in a more congenial and collaborative mode, and helping each other and having your teachers help you as you help your teachers. And that's not just medicine, that's everything. Not just healthcare, that's everything. We've got to do this together. I must say, I came into this conference yesterday, looking at this conference, came to town yesterday, and had this sense of, what are we going to say? And look at you, the 3 of you. You've created a great set of insights and observations and modeled resilience. I'm very grateful to the 3 of you for this, and grateful to those of you who have come here, and to those of you who are on the long, busy distance call. And I thank the organizers for being so adept at accommodating to the numbers and the changing issues, because these things begin with one thought in mind, and then, of course, there's reality intrudes. So thank you to everybody, and I personally feel that this has been an excellent session, and I will turn it over to whoever is now going to take charge. So thank you.